Okay, I have 86, 87, and I'm sure others will join, but it's 8:30 and we'll get started. So we had promised about every other week medical grand rounds during the summer to do updates on COVID-19. And so hopefully you all got the dates. The subsequent dates after this one are, there's a date later in July, July 30th, and then 2 dates in August. And then that'll take us to Labor Day. And after Labor Day, we resume our weekly medical grand rounds schedule as we always do. So I'm gonna start. We have 99 participants now. I'm going to show you the most recent hospital epidemiology data, which will only take a couple minutes, and then hand over to Dr. Walsh. So you should all be seeing my screen at this point. So these are data as of yesterday. And as you've all probably heard, the numbers are going down. So the Rgh number yesterday was 30 patients in the hospital, 6 discharges, and 1 death. And you can see the numbers at the other hospitals are relatively small. This is the laboratory testing data. As you can see, large numbers of patients are being tested every day. On July 7th, we tested almost 1,400 patients with only a small positivity rate. So if you look down here, the number of positives is in the less than 1% range. So these are the number of confirmed COVID cases by facility across the system. So again, July 7th, we have a total of 43. And if you look back the last several weeks, the number has steadily been going down. And these are the confirmed discharges. So that's basically the data. It looks like things are on the downswing. There is the possibility of a second spike sometime later in the summer or in the fall, but at least at the present time, seems like we're doing well. So I'm going to stop sharing, and I'm going to do a quick survey because we now have 130 participants, and I'd like to see who's on. So which of the following describes you best? Primary care physician, hospitalist physician, specialty physician, etc. You see the options. So we have about 20% primary care physicians. I have 102 responses. I'm going to end the poll. So sharing the results here. This is what we have in the audience, about 20% each of primary care physician, specialty physician, and APP, 13% nurses, and then a smattering of others. So at this point, I'm going to ask Dr. Walsh to share his screen and start his presentation on serology and vaccine development. Dr. Walsh.
Morning. Nice to, I guess, sort of see everybody. So today's topic really is to go through some of the more recent data on and the prospects of developing a vaccine, and to also talk about understanding antibody. Obviously, these two topics are intertwined very significantly. So I'm going to start with what today's topics will cover, We're going to review some of the history and basic virology of coronaviruses. And the reason I'm doing this is because it's actually quite important to understanding some of the issues regarding the development of vaccines, and also understanding some of the problems we may encounter as we go through the development process. I'll talk about general approaches to vaccine development and give you a sense of the pipeline, and specifically talk about vaccine development globally in the US, but most specifically here at RGH and in the Rochester area. What are the achievable goals of a vaccine? And then review some of the potential reasons for why they may fail to protect us. And I'll also review at the end status of antibodies, both as diagnostics, therapeutics, and prophylaxis for coronavirus infection. So this virus, as probably some of you know, is an RNA virus. And it is a very ubiquitous type of virus. It's a class of virus, perhaps one of the most common types of viruses that affect virtually every animal species, often with a variety of disease entities such as hepatitis, gastroenteritis, pneumonia, carditis. Almost any organ system can be infected with various coronaviruses. And prior to SARS in 2002, people really didn't pay much attention to it except for farmers. So, for instance, pig farmers, cattle farmers, etc. They paid attention to coronaviruses. There are currently 7 human strains, and they are categorized into 2 classes, alpha, or actually 4, but I'm showing 2 here, alpha and beta coronaviruses. The top 4 here, OC43, NL, which stands for the Netherlands, 163, those are alpha coronaviruses. 229E and HKU, which stands for Hong Kong University, number 1 is their number 1 isolate. Those are beta coronaviruses, as are the SARS coronavirus, now known as SARS-1, and MERS, which is the Middle East respiratory syndrome virus, which was thrust upon us via bats and camels in 2012. And then, of course, the current SARS coronavirus, known as SARS-2. So these are the 7 human strains that circulate or that have circulated in humans. The top 4 there, OC43, 229E, and L163, and HKU1. These have been well known since the 1950s and circulate every year during the winter. They have traditionally been called common cold viruses, but we've studied these viruses, Dr. Balsey and I, over the years here at RGH, and they actually contribute to a large percentage of the respiratory admissions during the winter, with a sizable and appreciable morbidity and mortality. So I think it's not that surprising that new viruses in this category, such as SARS-1 and SARS-2, cause significant disease. This cartoon gives you a sense of the sort of interdependence of the various species that become infected with the coronaviruses. And you can see at the apex of this little cartoon is the bat, and that's not Batman, unfortunately. It's the bats that live in caves, live in our houses, and so forth. And the bats can directly infect camels with MERS. They can directly infect civet cats with SARS-1, and can infect humans directly, which is what has been proposed for the current SARS coronavirus, that it may have come directly through the bats. You can see here we've got a cow and some of the coronaviruses, for instance, OC43, was thought to have emerged initially from cattle well over 1,000 years ago. And so, you know, it's interesting to speculate what might have happened at that time when a brand new coronavirus came out of a cow into the human population. So one of the first things to think about in trying to develop a vaccine is immunity to SARS coronavirus 2 possible? And then what are the achievable goals of a vaccine? So ideally, you would actually stop infection from occurring. That is, you would completely stop any shedding of virus, whether it be asymptomatic or symptomatic, that you would simply shut down the virus completely. That would be a wonderful outcome from any vaccine study. The second issue would be, can you stop symptoms? Can you prevent upper respiratory symptoms, lower respiratory symptoms such as cough or wheezing, sputum production, shortness of breath, for instance? That would be a reasonable, achievable goal, for instance, for a vaccine. It does not mean, however, that you've stopped shedding of the virus. And we'll get back to that in terms of the value of a vaccine, as well as the value of having been infected in the past. But what about certain outcomes? Influenza-like illness, which is essentially a URI or cough, lower respiratory tract disease. Can you stop hospitalization as an outcome? Respiratory failure, meaning going on to a ventilator, and then ultimately death. And these are fairly hard endpoints that are easy to count and easy to see, but are less frequent. And so these are some of the potential achievable goals. We certainly would hope we could achieve some of these outcomes of hospitalization, respiratory failure, and death with a vaccine, and possibly even reduce these symptoms here of lower respiratory tract infection. So what is the data for coronaviruses? Well, there's actually very, very little. This is data from a study that was done in the Common Cold Research Unit at the United Kingdom. Back in the 1960s, 70s, and 80s, there was this Common Cold Research Unit in London and Oxford that would bring in healthy volunteers and infect them with all sorts of respiratory viruses, from rhinoviruses, as well as coronaviruses and influenza viruses, etc. So in this study, they took 33 healthy volunteers and they infected them with a human coronavirus, 229, I'm sorry, I'm missing the 9, 229E, which is an alpha coronavirus. And remember I said these other viruses are beta coronaviruses, the ones that we're dealing with right now. So whether this holds for this is yet to be shown. But what this study looked at was the outcome of infecting these individuals. And these are individuals who all have previously been infected with 229E, growing up as children and then into adulthood. And so they all had antibody to the virus. And they looked at the outcomes, moderate illness, mild illness, and they looked at neutralizing antibody titers, and I'll just focus on that. Those who had moderate illness had relatively lower neutralizing titers than did those who had mild illness. And this was very statistically significant, and it suggested that the presence of serum neutralizing antibody to this virus could convert a moderate illness into a mild illness. They also looked at nasal IgA. And again, higher titers of nasal IgA to this virus were able to convert a moderate to a milder illness. I think it's important to point out, though, that you still could infect these individuals. So it wasn't completely protective. In other words, it reduced the symptoms, but not the actual ability to infect them. All right, so now let's turn our attention to the SARS-2 coronavirus that we're dealing with at this time. I'm going to point out some important characteristics. First of all, it's an enveloped virus. That's the envelope here. It's a lipid membrane. That membrane comes from our cells. Our respiratory cells that are infected donate that lipid membrane. It's a single strand of RNA, and it's of negative polarity. And I know most of you have not heard about that since you were in medical school or perhaps college. And it's depicted here as a linear single strand of RNA. Up at the top, it shows the genome pattern, and the green here is what's known as the spike protein gene, and that's one that we're going to now focus upon. And here it is shown here in this cartoon, the spike protein. There are two other proteins in the envelope, but this is the meat of the matter that we're going to talk about now. This is what it looks like if you could look at it under an X-ray crystallography assay. So it's what's known as a class 1 fusion protein. And I'm pointing out here that this is just like respiratory syncytial virus. And this is one of the links between respiratory syncytial virus and coronavirus research that has taken place prior to the pandemic and since the pandemic. And one of the reasons that we're involved with the research on developing a vaccine for coronavirus has to do with the fact that Dr. Falsey and I have for the last 30 to 40 years been involved with respiratory syncytial virus work, both epidemiology, immunology, as well as vaccine development. And so we've been very much involved with the RSV programs because these proteins are very similar, the RSV fusion protein and the SARS spike protein. We've been involved with this as well. And I just want to point out this green piece at the top, and this is the receptor binding domain. This is the portion of this protein that binds to the ACE2 receptor on your cell. This spike protein, as shown over here, is composed of two components, a 1 and 2nd component known as S1 and S2. And here they are in what's known as a ribbon diagram. Each of these molecules, 3 of them together, come together as a cluster, and that actually forms the spike protein. And so what you can see here is this blue and this beige here and the yellow. This is the S2 portion of the virus, and the S1 is this receptor binding domain and other portions down here. And I show 2 of them, 2 of these molecules, and I won't tell you what's the difference between them until we come back to the next couple of slides, but it's actually very important. And I want you to look at the green portion. So this is what the virus looks like if you were to look at it standing up and take a picture of it from the top looking down. And this is the receptor binding domain here, and here, and here. And it's here, and here, and here. And what this is showing is that if you go from this one here, where this receptor binding domain is sticking up a bit, and you can see it here, sticking up on this one. And this one is sticking up, but this one is down. And that's shown here from the top. And here it is with all 3 of them sticking up. And so this virus is actually somewhat alive. Sort of creepy, right? This protein the spike protein is actually dynamically moving in that the receptor binding domain goes from a closed position like these, where it covers up these green parts, to an open position like it's shown here. And then you start to show the core of this protein. And this is how it works. So here is the viral membrane. Think about this as the viral membrane. Over here is the cell membrane. You have the ACE2 receptor up here on the cells, on the respiratory epithelial cells. And the virus has this spike protein receptor binding domains in the down position. It's known as the head down position, which periodically pops up, either 1, 2, or 3 of them popping up. And when it pops up, it can bind to the receptor. And when it binds to the receptor, 2 things happen. First, this bluish part sheds off, and the green parts become a hinge and, like a harpoon, stab into the cell. It then snaps upon itself and fuses the virus to the host cell, and that's how it gets in. So why is this important? Well, if you can block this reaction with an antibody, or even perhaps a molecule, you can stop infection of the cell. And so this is the concept of the vaccine development that's going on. Produce antibodies to the spike protein, and most specifically, produce antibodies to the receptor binding domain on the spike protein to interrupt this ability to bind to the cell. What's interesting and what's critically important is that antibodies to this portion of this head down spike protein receptor binding domain may not, in fact, block this interaction. You need it to this very tip. So this is one of the reasons why developing vaccines can become very difficult. All right, so this is the goal. Let's produce antibodies to the receptor binding domain and to the spike protein. And what are the approaches that are currently going on? Well, inactivated virus. This is very simple. It's like flu, polio, hepatitis B. You simply grow the virus or take the virus, pellet it in a test tube, kill it by inactivating it with something like formalin, and inject it into a person. So this is a straightforward, very rudimentary, not very scientifically sophisticated way to produce a vaccine. But in the case of polio, it was highly effective, as we all know, as well as with hepatitis B. It also works with tetanus toxoid. The second way is to use purified subunit proteins, such as let's purify the spike protein, or perhaps purify the receptor binding domain portion of that protein, and use that as a vaccine. That's like the split subunit flu vaccines, which are effective. It's like tetanus, it's like meningococcus. So these are tried and true ways of inducing an immune response that is protective in some situations. Third way would be a live attenuated virus. That is, let's take SARS coronavirus 2, let's attenuate it in some fashion, make it less virulent, and give that as a vaccine. So smallpox worked very well for that. Yellow fever works very well. Measles, mumps, chickenpox, etc. So there's lots of examples. Influenza, the live flu mist, works in this way. So these are sort of the tried and true methods that have been used in the past for vaccine development. And these are all currently being attempted for SARS coronavirus. Then there's vectored vaccines. Now, a vectored vaccine is where you take one virus, such as an adenovirus, which can infect humans, modify it such that although it can still infect you, it cannot replicate and cause disease. And such as the spike protein gene for coronavirus. And this is a, I'm sorry, I'm going to go back. This is a method that is essentially untried except for one situation, and that is the Ebola vaccine, which is quite successful. And it used a virus known as VSV, or vesicular stomatitis virus, which causes herpes-like lesions in pigs, but can be used to prevent Ebola by simply taking the Ebola gene and putting it in VSV and then giving that as an injection. So this vectored vaccine approach is one that is very popular right now as likely to be effective. And then there's genetic vaccines, DNA vaccines and RNA vaccines. And these have never been done and never been used for or licensed at this point for a viral infection. All right, so vaccine development, and where are we going? Well, normally vaccine development takes many years. You've all heard this in the news and on the internet. It takes years and years and years to develop a vaccine, and it's absolutely true. The fastest vaccine ever produced was Ebola, and that took about 3 to 4 years, and that was a record. We're now trying to do this in under a year. Normally, you do a lot of laboratory studies, preclinical studies. You then do preclinical studies in various animals, and then you start to go into clinical phases, which is where we are now. All of these have been already done, these first 3 steps through the animals with the various vaccines. And now we're into clinical phases, phase 1, into 2, and then into 3. Generally, this period of time takes several years. Phase 1 generally will take anywhere from 6 months to a year. This has been pared down to about 2 months. Phase 2 often will take a year or 2. This is going to be very much abbreviated. And phase 3, these studies take as long as they need to show that the vaccine actually works. The number of people in each of these phases is very variable. Phase 1 studies generally are about 100 people. Phase 2 studies are generally about 1,000. And phase 3 could be up to 30 or 40,000. So these are the usual patterns of development. So this is not a cartoon from The Simpsons. This is from Washington, D.C., Operation Warp Speed. This is their emblem for rapid development and then deployment of a coronavirus vaccine. Here are the vaccines that are in development that are going to be attempted for phase 3 trials, or that are planned for phase 3 trials at this time. And from that list of types of vaccines that I showed you, on here are several different types. We have RNA vaccines here, Moderna, and then Pfizer. We have adenovirus vectored vaccines here. This is the AstraZeneca chimp adenovirus vaccine that you've heard about. This is the Oxford vaccine that has been purchased by AstraZeneca. You have Johnson & Johnson through Janssen, or Janssen. They use an adenovirus, which is a human adenovirus 26, one that rarely infects humans. Both of these vaccines have the spike protein inserted into them. Then Novavax has essentially a protein vaccine which is formed into a nanoparticle, and it has an adjuvant. And then most traditionally would be the Sanofi Pasteur vaccine, which is purified protein, the S protein. All of these companies here that I've listed with this red arrow, have been very much involved with respiratory syncytial virus vaccines and have developed these platforms, the messenger RNA platform, the adenovirus vaccine platform, the nanoparticle platform, and purification of proteins. And they've all been done with respiratory syncytial virus, and we've been working with them for that program for many years. And it's, again, one of the reasons why these are why we're here at Rochester General working with some of these. I'm going to spend some time on this one here, the Pfizer RNA vaccine, and messenger RNA vaccines in general, the Moderna vaccine, which you've all heard about with what are known as promising data that has come out recently in the press. All right, so how do messenger RNA vaccines work? Well, remember I said that this virus is a RNA virus, and it is a negative strand RNA virus. A negative strand RNA virus is, in fact, a messenger RNA. So essentially what this does is it simply takes a piece of the gene of the coronavirus that codes for the spike protein, and it is the message for developing the protein that the cell can use. And so it was a very straightforward approach. Simply take the message or the sequence in the gene to produce synthetically a messenger RNA, and what you do is you inject it into the body, into the arm, gets into the cell. That's not such a simple process, but it's been worked out. And then you develop an immune response and hopefully memory to that immune response. So it's a very straightforward way of going about making a immunogenic vaccine. Technically, there are a lot of difficult spots, but these have been all worked out in the last 10 years, and they were ready to go when this epidemic or pandemic hit. So there is actually multiple ways of using and producing these vaccines. One is known as an unmodified messenger RNA, where it's just standard messenger RNA using nucleotides that are normally found in messenger RNA. These tend to be very reactogenic and tend to be very potent stimulators and adjuvant for T-cell responses, and tend to be difficult to tolerate. A nucleoside modified messenger RNA, which is what the vaccine produced by Pfizer uses, has a modification of the message to some extent, so it makes it less reactogenic. And then there's a type of messenger RNA which is self-amplifying, which is a neat little trick where you add another piece of genetic material that allows this messenger RNA, to, once it gets into the cell, to replicate itself over and over again. Not forever, it does shut down, but it means that you get a persistent stimulation and production of protein in the cells that become essentially infected by this messenger RNA. And so this is a technique that some of the vaccine strategies are using. So here are the two Pfizer vaccine candidates, messenger RNA candidates, one of which we have been working with for the last 6 weeks here at Rgh. The first one just contains the message for the receptor binding domain. We have not been working with that. That has been done in collaboration with our the group that we're working with, both at NYU and at the University of Maryland. What we've been doing here is the entire spike protein, which does contain the receptor binding domain, and it contains 2 small mutations in this messenger RNA that stabilize this receptor binding domain in the head-up position. Remember, I was talking about how it's important to have the right configuration of the protein that's produced. Both of these can be packaged. They're packaged in lipid nanoparticles, shown here. These are given intramuscular, or they could even be given intravenously, and they're taken up by cells. The message gets into the cell, and the cell makes the protein that you're interested in. So here is recent data from the NYU and Maryland group. This is a group that we're part of, and I've just underlined the fact that we're doing this at Rochester General as part of this consortium. This is a phase 1, 2, and phase 2 study looking at safety, immunogenicity of this RNA vaccine in adults between 18 and 55 years of age. And this is an interim report. We're also studying the entire spectrum up to age 85 in this study. That data has yet to be fully developed, and once it is, we'll be able to show that. This slide simply shows the reactogenicity of these vaccines. This upper shows some of the systemic kinds of symptoms: fever, fatigue, headache, chills, vomiting, diarrhea, muscle pain, joint pain, and how many people had to take medication. And these are simply the different doses that were used: 10 micrograms, 30 micrograms, and 100. And although as many as 80% of people at the 100 microgram dose felt fatigue for a day or so, by and large, these were relatively mild to moderate complaints. And the conclusion was that these were relatively well tolerated. This is after the first dose, and these are the numbers down here below after the second dose. And you can see that after the first dose and then the second dose at the 30 microgram level here, there was more reactogenicity. And that's simply because you've revved up the immune system with the first dose, and then when you boost it, you've got a lot more T cells and a lot more B cells that are reacting to the vaccine. But this is the important data. This is the antibody responses, and I'll spend a little time here. This is antibody that binds to the receptor binding domain. That's the head-up receptor binding domain site that you want to get antibody developed to. And what this shows is the placebo group here, and they have no to very low levels of antibody to the receptor binding domain in this assay. These are the vaccine groups here. The light green is the 10 microgram dose. This is a 30 microgram dose, and this is a 100 microgram dose. And I'm just going to focus over here on the 10 and then the 30 microgram dose. So the vaccinees are given the vaccine on day 1. By day 21, they've developed reasonable levels of receptor binding domain antibody. And then a week later, on day 28, after the second booster dose, which is given on day 21, the titers go up, and they are persistent for another week. And this is, like I said, this is very preliminary, very early data on this vaccine. You can see here with the slightly larger dose of 30 micrograms, on day 21, before the booster dose, the titers are a bit higher, and then after the booster dose, they go even higher. Excuse me. So what's the comparison? Well, the comparison is this column over here. This is human convalescent serum. So this is serum from mostly outpatients who have had mild to moderate infection. And this is their receptor binding domain immune response. So you can see that the titer here in the people who have recovered from coronavirus infection is actually somewhat lower than the titers that have been induced by this vaccine. I'll now drop, whoops, go back here. Now I'm going to drop down to the second figure, B. And what this shows is the neutralizing antibody response. That is the ability of this antibody to not just bind to the receptor binding domain of the spike protein, but to actually prevent the virus from infecting cells. And I'll start with showing you the human convalescent serum as the basis for comparison. The mean titer of neutralizing titer was 94 in this group of 30, roughly 35 subjects. These are the titers that were achieved after using the receptor binding domain 10 microgram and over here the 30 microgram dose. This is after the boost. And you can see that the neutralizing titers were significantly higher than those seen in patients who've recovered from coronavirus. So you can make a few assumptions, which you'll have to make. Number one is you'll have to assume that people who've recovered from the coronavirus infection have made a protective immune response. Do we know this? No, we don't. We don't know this because this is a new virus and we have not had the opportunity to see whether this group of people who've recovered are in fact not susceptible to reinfection. So we don't know that yet. So therefore we can't fully conclude that these levels of antibody, 267 here and 168 here, will actually protect the patient. But it certainly is encouraging that this, as a vaccine approach, may be successful. The second vaccine I'm just going to talk about gives you a sort of a concept of the protocols that are used. And this is the AstraZeneca adenovirus vectored study. And this is the study design, sample size, et cetera, that I'm going to show you in the kind of regimen that's going to be used. First, it's about 30,000 people will have to be in a efficacy trial. Now, the AstraZeneca vaccine is an adenovirus vaccine. It is going to be expressing the spike protein in its entirety, not just the receptor binding domain. And the ratio of placebo to actual vaccinations will be 1 to 2. That is one for every one placebo, 2 people will get the vaccine. So the plan is to immunize approximately 1,000 people locally. This is going to be done through the University of Rochester's Vaccine Trials and Evaluation Unit that Dr. Falsey is director of. And part of this study will be done here at Rochester General as well. But up to 1,000 people are potentially locally will be enrolled in this study. The study regimen is still being, well, it's actually, the discussion has now concluded that 2 doses will be needed. And so 2 intramuscular doses of this adenovirus will be given approximately 3 weeks apart. It will be done in people over 18 years of age who are medically or have medically stable chronic diseases, but who are going to be at increased risk for developing acquisition and for developing coronavirus disease that is significant. So this will include people of a very mixed and diverse ethnic background. It will include groups of people with underlying cardiac and pulmonary disease, diabetes, obesity, et cetera, hypertension, the kinds of illnesses that we know are associated with increased risk. Just very quickly to point out that cellular immune responses are also important for immunity, and we know far, far less about these. This is a graph from one of the better immunology centers in the world, Alejandro Seti and his group. And what this simply shows is that CD4 T cells and CD8 T cells, shown in this lower graph, to the COVID-19 virus, to the coronavirus, are induced by natural infection. And it has been shown, at least with the adenovirus vaccines in both monkeys and in humans, that they also are developing T cell responses to these vaccines. So that may also be helpful in addition to the antibodies that are induced. So why might it not work out the way we expect it to? Well, let's talk about the virus. So the virus started in China, spread to Europe, and then spread to the US. The colors here are representing some mutations that have occurred in the virus. And I think you've seen in the press recently information about mutations. And this simply shows in bright colors the various clades or slightly different viruses that are circulating throughout the world from China. As it transitioned over to Europe, the colors here shown these changes, and then in the US, Canada, and Mexico, essentially North America. And you can see it down here. Here's the North American and US viruses, which are genetically different than those circulating in other parts of the world, such as here in Europe and in Asia. So genetic mutation could ruin the vaccines potentially. If the change in the sequence of the receptor binding domain results in the failure of antibody to bind to it, at least the antibody induced by the vaccine. This is a problem with influenza virus. We don't know that much about mutational changes yet in the SARS coronavirus. This simply shows estimated rates of mutation. It's estimated that there are about 24 to 25 mutations on average. That's what this black line shows, the number of mutations on average that are occurring over time. And it's estimated that it's about 24 substitutions per year. Now, where these substitutions occur and in what genes is important. If they occur in the receptor binding domain of the spike protein, that could be a real problem. If they occur in other locations that are not as important for immunity or induction of immunity, then that will be less important. But it also shows the splay here. And again, this is the US over here. And you can see that there seems to be more red balls up in here than that is indicating more mutations, that is the number of mutations being greater in this US isolate pool. And like I said, if these mutations were to occur in the receptor binding domain, this could spell some problems. So recently there has been a mutation that has been identified at amino acid number 614, where there is a D to G change in the sequence of the protein. And that's what these yellow bars show. These are the mutation viruses, and these are the non-mutated viruses. And you can see across the world the difference. Over here in China, very, very few of the viruses have mutations. Whereas in the US, and that's what's shown over here, there are 75% of the viruses have this mutation as shown here. So what is this mutation? And this is recently hit the press because this virus with this mutation seems to be, at least in tissue culture, that is in the laboratory, more infectious. It has been speculated that it may allow easier transmission of the virus. People have wondered whether this might account for why we're seeing more recent activity of this virus in parts of the US. However, what they have also been able to show is that it has not affected the ability of antibody to bind to the receptor binding domain, which would therefore mean that it should not negate the effect of a good immune response to any of the vaccines that are currently in trials or planned to be in trials. Second reason why it may fail is there's this theory of antibody-enhanced disease. And just very simplistically, what the concept here is that antibody that can bind to the spike protein if it does not neutralize the virus, but still binds to the virus, will allow, as shown over here, a mononuclear or macrophage cell to bind the virus through the Fc receptor of the antibody. And so even though this cell might not normally get infected, because these cells have Fc receptors on them, if the virus is bound up by an antibody that can't neutralize it, the cell can take it up and you can actually get increased infections. And you're infecting monocytes and macrophages, which produce a lot of inflammatory cytokines. This is a theory. It's not been proven to actually be important in coronavirus diseases, but it is a theory, and it is something that people are going to be looking for as we go through these vaccine trials. And let me just finish up then with a little bit on antibodies. Antibodies and their role in coronavirus infections. First, antibodies can be an epidemiologic tool with certain caveats. They can be a good guide to potential vaccine effectiveness. That is, if we can make a correlation between the level of neutralizing or receptor binding or spike protein binding antibody and the actual effectiveness of the vaccine, they can be very useful then to predict which vaccines will work. They can be used as therapeutic drugs, either a monoclonal or polyclonal antibody. And I say maybe here because by and large, antibodies have been most effective, not as therapies, but as prophylaxis. And that's the last point here. And this is potential only because it's not been shown at this point whether or not prophylaxis will work in this disease. So what are the caveats for it uses an epidemiologic tool? Well, a positive should tell you that a person's been infected previously. It takes about 10 days to develop antibody. So if you have antibody, it says you've probably been infected at least 10 days ago in the past. A negative tells you that you've not been infected, but, and we have data from Rgh to support this data that also is in the literature, that up to 30% of people with mild infections fail to induce antibody at all, which means a negative test may not mean you have not, in fact, been infected. Positive tests also can have false positive results. And so these tests have yet to be perfected as epidemiologic tools. But you do see a lot of information coming out, and this will be sorted out very shortly. It can, as I've already pointed out, can help define protective potential of a vaccine. What about treatment? Well, monoclonal antibodies, and the trials are going to be here very soon. The ability to make very specific monoclonal antibodies to very specific sites on the various proteins, for instance, the spike protein and the receptor binding domain are actually well developed, and these trials are already starting in the US, and they will be here in Rochester as well, again through the VTU at the University of Rochester that Dr. Walsh is in charge of. I might point out, though, that it takes a single amino acid change in the virus where the monoclonal antibody binds to lose the activity. So they are very susceptible to loss of function with virus mutation. With respiratory syncytial virus, this was very nicely shown when a monoclonal antibody that worked extremely well in the laboratory and in animal models was tested in infants. It worked completely for one RSV strain, but the virus mutated and it had zero activity in the study that was done. And it was about a $80 million study that was done throughout the United States, and it was a complete failure because of a single amino acid change that occurred in the virus. So this is one of the the susceptibilities to these antibodies working. But polyclonal antibodies or convalescent plasma, they have, those products have antibody to many sites, and so they are less susceptible to loss of function when the virus mutates. Unfortunately, there is really no efficacy data at this point whether polyclonal or convalescent plasma is effective as a treatment. I might want to point out, though, here that RGH, this little yellow highlight here, is a site that Mary Rgh+Mgr has included in the national study of use of plasma. This is immune plasma from previously infected patients given to people hospitalized here with coronavirus. And although there is no clear efficacy data because these studies have not been done in a placebo-controlled trial, they are being done with the hope that they may provide some benefit. And I'm looking at the clock, and I'm going to stop here and just go back and say,
did we lose you, Dr. Walsh?
The window for good from a vaccine is unfortunately closing. As more and more people become infected, less and less people will benefit from a vaccine. And so this is why, in the meantime, you need to wear a mask. So I will stop and stop sharing my screen.
You have
take questions.
multiple questions, Dr. Walsh. So I'll start with the first one. When you showed the antibody levels between day 28 and 35, they were dropping. Is that the natural course that they drop after that?
The answer to that is maybe. What we do know is that antibody levels tend to peak at about a month after most immunizations, and they do start to drift down somewhat. This is, we started doing these vaccine studies on May 4th. This is now 2 months later, essentially, this data. And we're going to be following these subjects for up to 2 years. Hopefully, certainly by then, we have something that will be helpful. But it is one of the issues, is how long will antibodies persist after immunization? I don't think there's any reason why they shouldn't be reasonably persistent for 6 months or so. If you look at natural infections, the same thing is true, that antibody titers do tend to fall. People who've started to look at this with natural coronavirus infection, the SARS coronavirus infection, the titers do tend to start to fall after several months. What the protective level required is just unknown.
Sure. So another question is, are the mutations that you see in the virus due to geography or ethnicity or just random?
Well, they're certainly random. RNA viruses, because they don't have great proofreading, do tend to make a lot of genetic mistakes. And this is one of the reasons why you get a lot of mutations. If they happen to benefit the virus, they'll persist in the population of viruses and in the people. This is thought right now, this is a debate. It's not clear whether this was a mutation that provided an advantage to the virus or it simply occurred randomly, is no different than its parent that it came from, and it's simply a matter of geography. And there is a school of investigators who feels that it's simply a geographic issue. That is, in the US, this mutation occurred early and it's simply spread, and so it's more common. But in the laboratory, it does make a difference in terms of infectivity. And so the thought is maybe transmissibility may go with that.
I'm gonna try to pool 3 questions because we have a whole bunch here and I don't think we're gonna get through all of them.
Mm-hmm.
So 2 of them relate to the toxicity of the vaccine. What is the toxicity? Is there a chance that the vaccine would actually increase the risk of a cytokine storm? And then there's a question about why do you have a placebo arm? And can you ethically justify a placebo arm in a vaccine study? And I think the 2 answers are related, obviously.
Well, they are. I think we don't know the answer to the first one. I mean, obviously, the concern, well, in terms of the side effects from the actual vaccination itself, thus far has been reasonably tolerated and certainly reasonable considering the benefit that would accrue from a protective vaccine. So the 2-dose regimen that's been used with the messenger RNA that we've been doing here, as well as the slightly modified version they're using at NYU in Maryland, which is the data I showed you. Those are very acceptable levels of side effects for a disease that is quite severe, like SARS. They're actually probably akin to the current shingles vaccine in terms of the side effects, reactogenicity. The second issue is, one that we don't know the answer to, and that is antibody-enhanced disease a real phenomenon? And whether or not by priming the immune system in such a way, you'll get a increase in cytokine responsiveness when you come into contact with the virus in your day-to-day life. And I don't think we know the answers to these questions. And will we know the answer? Probably, but not for a while, not for a long while.
So which is why you need to continue to have placebo arms.
Oh, you absolutely have to have a placebo arm. You know, it's interesting, in China, they have a killed virus vaccine. A company in China is making it. And without even testing it, they gave it to their military. This is before so there's no placebo group, and it was never even assessed. We can't do that in the US, at least not yet.
Okay. And then there's a couple of questions that relate to the ACE2 receptor that you showed. Is that being targeted in any way? Is there a role for ACE inhibitors, et cetera?
Well, that's really not known. I mean, that was a question back in 2002 with SARS. SARS-1, SARS-2, and actually one of the seasonal coronaviruses also binds to the ACE2 receptor. Interestingly, they bind to slightly different locations on the ACE2 receptor. So that antibody to the first SARS-1, does not actually protect you from SARS-2. Yeah. So small molecules targeting it, would an ACE, an ACE inhibitor actually be of benefit? I think these are questions we've all been asking. It's not obvious that they do. It's not obvious it's bad, and it's not obvious that it's good. And so the general consensus has been, well, just don't change things around. You know, if you're on them, stay on them. If you're not on them, maybe not add them.
So would immunocompromised patients be able to take the vaccine?
You know, immunocompromised patients are never included in vaccine studies. They are always added on later. So what happens is a vaccine will be tested in relatively high risk, but in immune competent individuals, shown to work, be FDA approved, and then they get used in immunocompromised groups. And you can retrospectively assess whether they are a benefit. but they're not included in studies directly. It just hasn't been done.
There's a question about the blood groups. There was that data from China that showed blood group A
Right.
make you more susceptible and so on. Does any of this immune stuff relate to blood group?
You know, I don't know. I haven't looked at that literature to see if it can somehow weave into the virology and then the immunity.
And then the last question, and we're going to stop with that, is do you have enough volunteers for your vaccine studies, and can people help you?
Well, we certainly don't turn people down. On the other hand, I'll just point out that the response in the Rochester community has been a bit overwhelming. When we first went public with the plans for pursuing the vaccine trials, within 12 hours, over 2,000 people contacted us, which is a bit overwhelming.
So the answer is you have enough. You don't.
But we still need to. So in our current studies, we're evaluating in phase 1 low-risk individuals. For phase 3 studies, which will be starting very shortly, we actually need volunteers who are at higher risk for acquiring the disease. So, the people we're enrolling currently in phase 1 studies and in phase 2 studies as well, these are individuals who are much like I am. That is, I wear a mask all the time. I have not been in Wegmans since March 20th. I stay out of trouble. So do our study subjects. And I'm not saying we're looking for people who are cavalier and going to bars, but we need to be testing these vaccines in groups that are more likely to come into contact with the virus. And this would include hospital employees who are actually frontline workers. It would include people in stores that are frontline workers. If, in fact, bars are open, it would be people who work in those places. So if the schools reopen, it would be teachers. It would be individuals who are going to come into contact with a lot of people and be at greater risk for acquiring disease. And the reason we need to study those people with the efficacy studies is because you have to have an infection rate within the placebo group that allows you to compare it to the vaccinated group. So that's a population that we have not, in a sense, advertised for. We were asking for people who are low risk, who are healthy.
So phase 3 would certainly include healthcare workers and
yes.
nurses on the front lines, technicians on the front lines, doctors on the front line, maybe.
Right. It would include, for instance, all the people employed at, say, nursing homes.
Yeah.
People who live in assisted living. Some individuals who live in nursing homes. People who are at greater risk. For acquiring infection based on their lifestyle, whether it's a lifestyle that is cavalier, which is unfortunate, or simply a lifestyle that requires them to be at some increased risk.
I don't think you want the cavalier because they won't be good study subjects.
Well, that's correct.
Yeah.
But,
you want people at risk, yeah. And
you do.
A lot of people
For the phase 3 studies.
Yeah.
Yeah.
All right. I think we're going to stop there. It's 9:40. We've gone a little bit over, but I think we got through a lot of the questions. Thank you very much. That was wonderful. You also did these serology studies in staff and so on. That's a whole other topic, so I'm not going to get into that today.
Right. We have a lot of data from Rgh specifically.
Yeah, maybe next time, if you send me a summary, I can present it. It's doesn't have to. All right.
Okay.
Thank you very much.
Right.
Bye.
Bye now.